Good morning, everybody. We're going to give it one more minute and get started, but really excited to have all of you join us this morning for a really important conversation about just the state of funding for the Health Center program, for the National Health Service Corps, and the Teaching Health Center program. So we'll get started here in just a minute. All right, everybody. I think we're going to give it 1 minute here. Really excited. I hope everybody had a wonderful weekend and a nice start to the week yesterday, whether you had the day off or you were working. We're really excited for the conversation this morning. I'm so privileged to be joined by absolutely stellar colleagues from 3 different health centers and Christine from the Association for Teaching Health Centers. So let's see, we're 1 past. I think we can go ahead and get started. So I'm Amanda Pierce-Kelly. I'm the CEO of Advocates for Community Health. I am also very fortunate to be the Executive Director of the Association of Clinicians for the Underserved. As I mentioned, I'm really excited to be joined by my colleague, Christine Serrano, who's the Executive Director of the American Association of Teaching Health Centers. We're just really appreciative for you to be joining us today. It is an extremely important and timely conversation that we're having about what is at stake in terms of funding for the Health Center program, for the National Health Service Corps, and for the Teaching Health Center program. We are really excited for you to be able to hear from folks on the ground at 3 different health centers who have direct connection to each of these programs and multiple programs in a lot of cases. And so they are experts, but they are dealing with the realities of this every single day. A couple of quick housekeeping elements. Please make sure you keep yourself muted, but you can always drop questions into the chat. We're going to be looking at that. We're also streaming this live to LinkedIn. And so if you're joining us on LinkedIn or watching from there, you can add comments. We definitely want this to be engaging in a 2-way conversation. And so we will do our best to take up those questions and comments throughout. And again, we've come together today to make sure that it's very clear what's at stake and to urge our champions and our leaders in Washington to take action as swiftly as possible to have long-term funding and increased funding for, as I mentioned, the Health Center program, the National Health Service Corps, and the Teaching Health Center Graduate Medical Education Program. All of these programs, I think as everyone on this call knows, but just as a reminder, funding for these programs expire in just weeks, March 8th. And so the timing of this conversation could not be more important, just in terms of, again, what the reality looks like from a day-to-day and what is at stake, but also what can be, and looking at the true need that continues to exist in terms of workforce, in terms of our patient base, and in terms of the pathway necessary to make sure that the workforce is built enough to be able to address that need. The National Health Service Corps and the Teaching Health Center programs serve as lifelines for the Health Center program to support placement and vital pathways to ensure that the healthcare workforce needed to serve these communities is intact. And I want to turn it over to Christine to both introduce herself, but also to speak a little bit more about that before we get into our panel discussion. So Christine, do you want to introduce yourself and please dive in a bit more?
Yeah, sure. Thank you so much. And Amanda, I want to thank you again for inviting us to join in this important discussion. The program is, the programs are set to expire in a little bit over 2 weeks, and without kind of immediate action and fully understanding the destruction that could happen without a multi-year fix for these programs, I think is really, really important. And so I'm Christine Serrano. I'm the Executive Director of the American Association of Teaching Health Centers. I've been in the health center world specifically with the Teaching Health Center program for the last 14 years. So since the inception of the program, so I've seen the Teaching Health Center Graduate Medical Education program grow from 11 programs across the country to now there are over 81. There's currently also 93 planning teaching health center programs that are waiting in the wings for the funding to stabilize and to grow to allow them to come on board. And so I'm really excited to have this discussion with many of the health center leaders from across the country. And to share a little context, there is a huge primary care physician workforce shortage. It's projected that next year there'll be a need for an additional 13,000 primary care providers, specifically in health profession shortage areas. Another 10,000 dentists will also be needed in 6,100 mental health providers. The Teaching Health Center program, along with the National Health Service Corps program, is working to try to address that gap and fulfill the need for these shortage areas across the country. And so we really need an investment into these programs to ensure that we are on track to provide the patient services in the FQHCs that are projected. FQHCs are projected to serve over 38 million patients next year. And so without an immediate fix for these, I think many of these FQHCs will essentially have issues serving their patients and maintaining system capacity.
Thank you so much, Christine. Yeah, I think just to dive in even a little bit more than that. So, and I know our colleagues are going to get into this, so I don't want to speak for them, but just to give a little context specifically for the National Health Service Corps. So there was significant infusion by necessity, honestly, into the National Health Service Corps over the past few years because there was such a severe strain on the workforce like nothing we've ever seen before due to the pandemic and other challenges. The field strength of the National Health Service Corps, which specifically places providers in health profession shortage areas, the largest proportion of which happen to be at FQHCs, at health centers. So the field strength of the National Health Service Corps is now around 20,000 providers. It's an extremely important tool for the health center program. It really is one of the most important recruiting and retention tools to make sure that those providers are in health centers to provide care to those communities who both lack access and frankly have those most in need. So when we talk about funding and the importance of this, and not just keeping it intact, but also that continued need, the National Health Service Corps really represents an interesting picture here, because if you think about where we are with healthcare workforce, how strained things continue to be, how difficult it is to fill vacancies that continue to exist, but also to keep your team intact. If funding for the National Health Service Corps is not kept at least at where it's been, ideally increase in order to address that additional need, immediately that field strength shrinks. So you go from a 20,000 person field strength down to wherever the funding will allow. The reality of what that looks like is health centers have to come up with a difference or they face losing staff. They lose that capacity to use that recruitment and retention tool to both bring in providers that they so desperately need to care for the patients that are in need, or they lose those that are on staff. So that is a good segue to introducing three really outstanding colleagues who are leading the charge at the health center level. Dr. Parinda Khatri, she's the Chief Executive Officer at Cherokee Health Systems in Knoxville, Tennessee. She is a member of Advocates for Community Health and serves on our board of directors. Dr. Adrian Billings, he's the Chief Medical Officer of Preventive Healthcare in Alpine, Texas, or Alpena. I feel like I've heard you say it both ways in Texas. He is also an alumni of the National Health Service Corps and served on the National Health Service Corps Advisory Council. He is a board member of the Association of Clinicians for the Underserved. And we have Dr. John Waits. He's the CEO of Cahaba Medical Care and Program Director and DIO at Cahaba UAB Family Medicine Residency in Centerville, Alabama. I just am so thrilled to be able to have each of you with us and to open up a really important conversation. So we'll start with just a general question for each of you today. That's, of course, top of mind. How is this funding uncertainty impacting your operations, your budgets, and just your day-to-day? Parinda, we'll start with you.
Well, thank you very much, Amanda and Christine. First, let me say what a privilege it is for me to be here and really give a voice to all the community health centers across the country who have been real gladiators in the past, decades, but certainly in recent years. So let me just start by telling you a little bit about our organization. Cherokee Health Systems is a federally qualified health center. We have 20 brick and mortar clinics across 11 counties, and we have a mobile clinic, and we have another 20 plus telehealth sites. We are located in inner city in Knoxville and Chattanooga, but really the vast majority of our sites are in rural areas in rural Appalachia. And for us, the health center funding is absolutely essential for us to be a resource, not just for healthcare. Community health centers are much more than healthcare delivery systems. We are woven into the fabric of the community. So, for example, in Washburn, Tennessee, which is a beautiful community in Appalachia, we are the only healthcare provider. Hospitals around that community have closed. Rural hospitals are closing at an alarming rate. And so the demand on us has been significant to sustain our ability to provide healthcare, preventive care. We provide primary medical care. We provide optometry services. We have patients who come in, we have elderly patients who come in and cry when they get their glasses because they've never been able to see before. This is really such a critical time for us as community health centers because the demand has been unprecedented, and for us to continue to be a solid foundation for all the communities we serve and really be an important economic engine for us, right? Not just in terms of who we hire, but when a local business needs help with an employee, they call us. If there's a problem with the farm, and we're seeing a lot of the opiate use disorder, substance use disorder, methamphetamine use, particularly in rural areas, people call us. And so we take this as an honor and a privilege and a responsibility very seriously. So it is absolutely essential for us to maintain a strong foundation, particularly during such a disruptive time. Both economically, socially, politically, you name it. Our communities are really need the anchors and a port in a storm. And community health centers have stepped up to the plate. We want to remain at the plate. We need to remain at the plate.
Thanks, Brenda. And I think you're so right when you talk about the foundation, and that's what's at stake. I think something that I just want to call out for the attendees in the room, something I worry is not being connected, and something that, because we have, unfortunately, or just the reality, we've been through this cycle multiple times where we have had to reauthorize funding for these 3 programs. And we've been, grateful to see that happen. However, there's a difference in what's going on right now. It's never been like this for a few different reasons. The workforce challenges that we are facing as a country and across healthcare right now is different than anything we've ever seen. The 340B program, which is an extremely vital, cannot overstate that, extremely vital program to the health center program, is eroding for a variety of reasons. We won't get into that today, but the reality is that program is eroding and it's having major implications. In addition to that, the cost of services, goods and services, and inflation is just a reality. And so the challenge this time, when we talk about, okay, every time there's a CR and it's a continuation of funding, while there's gratitude for that, and we haven't gone over the, so to speak, funding cliff, the reality is that's a cut because of all of those issues, because of the inflation, because of the cost of services. Keeping us whole isn't actually keeping us whole. That's a decrease. The reality is operationally, that looks like a cut. So the urgency right now and the nervousness that I have, quite frankly, is that as negotiations are continuing, and we're so grateful for this long history of bipartisan support, but as these negotiations and discussions continue, and the possibility of another CR or the possibility of a longer term CR, that is very, very concerning because of what I just described. This is not like it's ever been in the past. A longer term CR or even just another CR is quite harmful to us. So I'll pause there. I want to switch over to National Health Service Corps. And Dr. Billings, do you want to share a bit about your experience and sort of what this looks like for you?
Sure, and thank you so much, Amanda. I do appreciate the privilege that I have to really advocate for my patients and my colleagues back home in Alpine, Marfa, and Presidio, Texas, which are located in what the government calls frontier health professional shortage areas. So the most remote, the least population dense areas are called frontier HPSAs. And so our Community Health Center Preventative Care Health Services practices and has 3 locations in Alpine, Marfa, and Presidio, which are anywhere from 2,000 in population to 6,000 people in population. And we provide over 50% of the healthcare for this Texas-Mexico, far West Texas border region. And our clinicians do home visits for our patients who can't access in the clinic, and our family physicians deliver babies at the only critical access hospital in this 25,000 square mile area that we serve. And most importantly, we provide really evidence-based care in conjunction with a residency program through Texas Tech Health Science Center, where we're trying to train the next generation of family physicians for our rural communities. The National Health Service Corps is really personal to me. It really enabled me to go to medical school and know that I was going back home to practice along the Texas-Mexico border, which is where I felt called to go. This is the only place that I wanted to ever practice, and it really removed that financial burden for my then young family for us to return home to practice. And that was 17 years ago. In spite of just a 4-year commitment, I can't imagine serving any other population than my neighbors and friends back home. We really have our federally qualified health center. We really have depended upon the National Health Service Corps for recruitment, from anything from our nurses to our physician assistants, all the way to our physicians and our behavioral health workforce as well. And so we really have noticed since the pandemic and the attrition that has done to the workforce nationally, we really have struggled with recruitment for the past couple of years. And we're really using a lot more of our budget and our time now trying to find a workforce that is incredibly limited now after the pandemic. And so we really need this vital National Health Service Corps program that really cares for the vulnerable in our population. And even those who may be privileged. We at our community health center, we take care of anybody from the uninsured to the physicians in the community, the president of the rural university. And so we really do take care of who you think of as privileged, but without our health center, they will become even more vulnerable without the National Health Service Corps. And potentially, this does, we worry about operationability of all of our 3 sites and our 3 different service lines. We really do worry that a consequence of this is operationability for not only our service lines, but our health center in general. And this will have devastating public health consequences for our area. And nationally for our nation if we're not able to serve the 19 million patients that the National Health Service Corps clinicians currently serve. So thank you.
Thanks, Adrian. And just a quick note on the National Health Service Corps to level set for some who may not be completely familiar. There are 2 main components to National Health Service Corps. One is through a loan repayment program for those who have completed their training and they're looking for placement, and so again, the health profession shortage areas, that's where you're routing or you're looking at providers who can be recruited and retained through that loan repayment. The other component is a scholarship program, which operates very similarly, but that's a pathway basically to make sure that providers are embedded into these health profession shortage areas. And the great thing about the National Health Service Corps is that we have data that supports the fact that most of these providers stay in the community. It's also one of the most diverse programs in government in terms of creating diversity across providers. So it is one of the best federal programs out there, and it can't be overstated in terms of the importance to the health center program. But it also, I want to kind of take us into the next component of this, and the scholars component and the pathway that's so critical to making sure that we have the workforce right now, but we are also creating the workforce to bring us into the future, because the need is only growing. And so that is a perfect segue into Dr. Waits and speaking to our Teaching Health Centers program. So Dr. Waits, do you want to introduce yourself and share a bit?
Well, I'm John Waits. I'm a family physician in rural Alabama. I'm in Centerville. I've been here about 21 years, and I was a National Health Service Corps loan repair alumni. I was a geographical statistical aberration. I'm from the suburbs, from Tuscaloosa, and drank the rural medicine Kool-Aid in medical school, and the National Health Service Corps allowed me to experience a rural area. And like the statistics of the National Health Service Corps, I've been here for 21 years. And in medical education, so I'm at Cahaba Medical Care. We're an FQHC. The Cahaba UAB Family Medicine Residency is a teaching health center. We operate in 28 locations over 6 counties. Half of our organization is in rural Alabama. About half the organization is in the underserved western side of Jefferson County, which is essentially Birmingham. Our headquarters is in Centerville, Alabama. And about 10 years ago, we created a teaching health center. We got it accredited and funded. Medical education is pretty unique amongst the various professions that people might decide to go into after college. So after you finish medical school, you've got this 3-year apprenticeship where you can't be paid by a third-party insurance, but you have to complete it to get your board certification. And for over half a century, that has been hospital-based, Medicare-based graduate medical education funded. It's been based in hospitals, and that has made our training milieu in the United States the envy of the world, if you will. There's an example of American exceptionalism, as we say. But one of the things we noticed over the last 20 or 30 years is medicine got pushed more and more out into the communities. And if the funding stream is through the Medicare program, through the hospitals, how can we get the training out into community health centers and rural health centers? Well, a brilliant bipartisan solution has been the Teaching Health Center. So the Teaching Health Center Graduate Medical Education Program puts the location of the training in underserved areas. It's been bipartisan because it's been enormously successful. There's 3 times more likelihood for our graduates to locate in rural and or underserved locations. And that's been Cahaba statistics, and that's been the Teaching Health Center statistics around the country. It's bipartisan, it's transparent, it's accountable. And the question of what is the CR confusion and the budget process doing to teaching health centers? Well, here's the thing. We start recruiting for this unique period in a young professional's life called residency, this 3 years of apprenticeship. We start recruiting years earlier in medical school. And so the best and the brightest, even if they want to go to a rural area, even if they want to go to an underserved area, they've got to know that is the funding for my internship. I've got $200,000 worth of debt. I don't want to get into the middle of my internship and have the funding cut out from under me, and I've got to stop residency and try to find another residency a year later. It's catastrophic, and it's why actually some teaching health centers have looked at the economic climate and the funding climate and said, we don't want to participate in the program anymore. So we want that to not happen. Teaching Health Center has been an enormously successful program for rural and underserved areas, and stability will help us continue doing great things.
Thank you so much, Dr. Waits. I think, again, each of you sort of in your remarks, it spurs thoughts. And one is, I think, the predictability and the solvency and the continuity. And I think that is the case really across each of these 3 programs. It exists a little differently for each. But I think what you just called out, that being able, whether you're a student, and you're going into residency, or you're a National Health Service Corps loan repair, or you're a health center CEO, and you need to know, maybe there is so much need. And actually, I'm excited to get into more of our conversation, because we do want to talk about the need, which really is driving the discussion around why not just a continuation of funding, but an increase in funding is so vitally important. But before we get into that, Christine, let me hand it over to you because I know there's more on the teaching health center side, and I want you to have a moment to offer some questions as well.
Yeah, no, and I just want to thank everyone for kind of giving their context. I think with everyone kind of explaining their background and how, how they came to be within this health center world, it's very, very intertwined. National Health Service Corps, kind of GME, and everyone has overlapped in some sense. And I think we find that throughout the health center world, right? Like this is a recurring theme on why these programs are so interconnected and intertwined. Something that you mentioned earlier, Amanda, is why this year is different and kind of why this cliff is different. And I just want to emphasize that when we're looking at this program and looking at a CR and continuing this, it really, really is a decrease in funding. It is a cut in funding, specifically, for all programs, for the Health Center Fund, for the National Health Service Corps. And, especially for Teaching Health Center, we've been operating at funding levels that were set 10 years ago. And so if there's not an increase in funding and a stabilization of funding, I think we'll continue to see some programs drop out, which we've just started to see this year. And so just want to reemphasize that although a CR does continue the program, it is a cut in funding for all of these programs. I think I want to jump into hearing directly from you all on why are you finding that this year is more critical than ever? Dr. Brunda, if you want to go ahead and jump in.
Yeah, thank you. Well, it's interesting because we were just looking at our 2023 numbers, and we are an organization in Tennessee. 40% of our patients are on TennCare or Medicaid. 24% of our patients have no insurance. 24% of our patients have no insurance, and they're on a sliding scale. If it were not for us, they would get no care. Many private providers do not take Medicaid. 14% are on Medicare. So the vast majority of people we see, by far, 85–90% are either on public insurance programs or have no insurance. Last year alone, we had $11 million in uncompensated care. Let me say that, $11 million in uncompensated care. And that far exceeds our base grant that we get for 330 funding, which was set, as others have said, many years ago. So our uncompensated care far exceeds that. The number of people who need us continues to grow. And another, I think, critical point is our role in the community has expanded. This became very clear during the pandemic, where we had to move into the role of a public health service entity, vaccinating people, testing people. We were the people who went to the schools, who partnered with churches, who went to local businesses. Those collaborations were precious, and they're still there. And in fact, we were hearing that the demand, particularly for mental health services, so we're seeing unprecedented. I've been a clinical psychologist for over 25 years. I have never seen so much need for mental health services. I've never seen this level of pain and suffering. Our suicide rates are going up. People are turning to substance use. They're turning to all kinds of unhealthy behaviors, gambling, you name it. And they're coming to their healthcare home. And for many communities, it is the community health center. So we are in this pivotal moment in time where we really stepped up when the community needed us. That's our job. And the community needs us again. And it is absolutely critical for us to be able to have the resources, because as a CEO, I'm happy. Our entire revenue was 89 million, and 11 million, think how much more we could have done, but 11 million was in uncompensated care. And that doesn't cover all the case management we do. We have a supported employment program. We help people and we get jobs and be part of a thriving economy. We work with local businesses, and we work with people to work on their vita, help them with transportation. We have food pantries in every clinic. We have mother-baby programs where we give away, we have baby showers. All those enabling services and supporting services are what makes us unique and actually are contribute to the overall thriving of a community. It really does. So for us, when we look at our budgets and the impact on our budgets, I'm thinking, okay, I have to at least plan for 11 million additionally in uncompensated care. Plus, if if our numbers go up in terms of demand, which they will, then we have to think of that. But the other thing I feel very responsible for are our partners, are the churches who rely on us, our local hospital systems and ERs, who because of us, they are not getting as inundated. But they have told us, if you are not there, this is going to be devastating, because people need to go somewhere. So if we cannot expand to meet the need and be strong to meet the need, our local businesses will feel it, our local farms will feel it, our hospitals and our ERs that are already at the brink are going to feel it. And so that is a very heavy load to be thinking about, not just internally, but also the cascading impact, because we are so critical to the fabric and the entire continuum of wellness and support in the communities we serve.
Christine, can I chime in really quick too? Something that I think gets lost all too often is that primary care saves dollars. It actually puts dollars back into the system. We have data behind this again. So for every dollar spent, it's a $13 savings, downstream savings. That is the beauty of primary care. And so when Corinda is talking about this and what does it look like, and I know Dr. Waits and Dr. Billings can say the same thing. It is the same story at every single health center, and it works. And so when we talk about increased investment in these programs, it's actually saving the system billions. And we know that over the course of time, but that continues to go up. And then the other thing, and I think perhaps Dr. Billings and Dr. Waits, I know Corinda can get into this too, but the other thing that you mentioned is the social determinants of health. The complexity of the populations that health centers are caring for, that each of these panelists are seeing and their teams are seeing, the needs are very different and extremely complex. And the beauty of the health center model and the way that the National Health Service Corps and the Teaching Health Center program support is that it addresses all of those needs. And it is the community model, it's the consumer majority board, it is the fact that people who are actually consuming the care, the patients, are actually driving the way that that care is designed outside of the core components. So it's, I think, again, if there is a takeaway to bring back to Congress and just to raise awareness about, okay, our resources are scarce as a nation. We need to be really discerning about how they are invested and where they are placed. There is no better place than to put them into primary care, to put them into the health center program, the National Health Service Corps, and the Teaching Health Center program. Those three, which are so intertwined, you said it perfectly, Christine, will bring us savings as a nation. And so it's troubling that we're continuing to have this conversation, but I'm very optimistic and grateful because I see where it can take us. But Christine, I'll turn it back to you.
Yeah, no, and I feel like many of the programs are being forced to do more with less. And I think that's one of the main issues. At one point, the system is going to break because you're not going to be able to do that. Dr. Billings, do you want to share a little bit more, as well as, why this year you're finding it more critical than ever?
Thank you, Christine. And I echo Dr. Khattri's echo of just the impact that this is having and the strain that this is having on not only our health centers, but our communities that we serve. National Health Service Corps clinicians, where they mainly serve the location where the vast majority of the repayers in the National Health Service Corps serve are within community health centers. And these community health centers are both in urban and rural populations where otherwise there might not be access to care, would it not be for the community health centers. I really feel that clinicians who practice within HPSAs or health professional shortage areas, they're really domestic medical missionaries. They are really champions who are there practicing community medicine and community health. both within the walls of their health centers and in some instances providing vital services within the hospitals, the community hospitals where they serve. But more importantly, what I tell trainees is that as clinicians, we have to be combating those social determinants of health. And I think that is really what makes federally qualified health centers a little bit different, is that we are embedded within communities, and we have to be practicing medicine outside the walls of our healthcare facilities in order to really have a more significant impact upon our patients' health and their lives, to improve their lives, whether that be through education or housing stability, food security. These are the spaces, not only within the medical pillar of the social determinants of health, but community health centers have historically been impacting those other pillars within the social determinants of health. Again, practicing community-based medicine, both within and outside the walls of our facilities. And COVID just put an incredible strain upon our health centers. Oftentimes, as our community health center, we were the first healthcare organization within our area to receive the COVID vaccine, and we were tasked by our state government to begin vaccinating our tier one at that time. Early on in the vaccine availability, we were doing our vaccinating our frontline workers. And so we put our operations on pause, and our dentists were giving vaccines. Everybody was contributing, and we were just going from can until can't, vaccinating as many people as we could. And that continued for months, where we really had to do both, do full day vaccine clinics, as well as keep our other service lines, our behavioral health, our primary care, our dental care, and our pharmacy running at the same time with limited staff. And the consequence of this is we really had a brain drain as a result of this stress that the pandemic put upon our area. We actually lost 50% of our physician workforce for this 12,000 square mile area, 2 of which were our physicians, but 5 of our physicians, accounting for 50% of our physician workforce for this frontier HIPSA. We actually lost them to New Zealand. And so this was an incredible brain drain, and we have not been able to replace all 5 of those full-time equivalents. And so we're still running behind. And this means longer wait times for our vulnerable patients that need to be seen for their primary care, need to be seen for their behavioral health care and their oral health care. This really does, the consequence is delayed care and vulnerable patients arriving, more sick, and even in some cases probably having bad outcomes because of a lack of workforce that's available. And that the National Health Service Corps really does enable a more robust workforce to try and meet the needs of our deserving patients. They should be getting more care and not less care. And it should not be that a rural zip code or an inner city urban zip code is a risk factor for a patient's lives. And that's truly the reality that our patients that we serve are living in. Thank you.
Thank you so much. And it's interesting that you're talking about some of the workforce shortages that you're seeing post-pandemic. Like a lot of those issues aren't super apparent until 1, 2, 3 years later. And so these are issues that we're just now seeing that seem like 4 years ago seems like a long time when we're talking about COVID, but it's really issues that I think that are now on the forefront when we're talking about workforce challenges that we're now trying to address. Dr. Waits, do you want to go ahead and talk a little bit about why the funding is so important for right now, and essentially what happens if funding does remain the same?
No, thanks, Christine. And I just want to co-sign and echo what Corinda has said about the Tennessee experience and Adrian has said about the Texas experience. I just echo that for Alabama. We've all lived through a lot, and so. Yeah, Christine, to answer your question directly, what would it mean if there was kind of merely level funding? Amanda said earlier, we're so grateful that the reauthorizations have happened, every couple of years. But I think everybody that's perhaps listening to this call has experienced something in their life increase in cost. Half a decade ago, a bipartisan Congress, as a part of one of the reauthorizations, commissioned a study of what does it take to run a teaching health center. Remember, teaching health centers is this important pipeline for community health centers and rural health clinics to graduate doctors that have a 3 to 4 times more likelihood to stay in these communities. And they said that it cost about 40% more than we're funded now. So if we were to get level funding, the 80 some odd teaching health centers, if we were to get level funding and have the same exact dollar amounts that were reauthorized in, say, 2018 or 2020, that's the same amount, but that purchasing power is, 20% less, just like happens to us at the grocery store. Some of our vendors are sending, next year's contract is going to be 30% more expensive. But our cost of living, of incoming grants and Medicare and Medicaid, these things are going up 2 or 3%. I know this sounds boring and financial, and is this an accounting press conference? But this is the life. We are nonprofit community health centers, and our margins are razor thin because guess what? We don't make profits. We invest it back into the communities. So we are doing less as inflation kind of takes hold. And so it would mean the involution of the programs that are able to stay open. It will simply mean some of the existing programs that have had a storied decade of absolutely transparent success closing. A few have closed already, and it will mean some 70, 80, 90, I forget your number, Christine, but that are in the Teaching Health Center Development Program. There are other communities that need a teaching health center to do what's happened in the communities that we have a teaching health center. All they need, in some cases, they've gotten accreditation for their program. They just need stable funding, and they can have the story that's happened in Bibb County, Alabama, where over a 10-year period, Bibb County has gone from a HPSA score of 19, being one of the most underserved counties in rural Alabama, to a HPSA score of 10, to the point that one of our graduates a couple of years ago was unable to get a state scholarship to stay. We had to find a more underserved rural county to place her. So it's just a success story, but level funding is not level with what we've been through economically over the past 5 years. So it really does need to be addressed from a numerical macroeconomic standpoint, but also from just growing a program that has had bipartisan success.
Yeah.
Go ahead, Christine. Sorry.
No, I was just going to say thank you to all of you, kind of for sharing your perspective. I think it really is helpful to hear, kind of boots on the ground on kind of what you're experiencing and these questions that you need to have with your CFOs and your partner hospitals, and how do you continue providing X amount of services, or when you're looking into the future, what services are you going to have to scale back? And so, it's a really difficult position to be in. Amanda, do you want to go ahead and take over?
Yeah, I mean, I think a couple other things to call out. Dr. Waits, you raise a really good point. So national average, just to be clear, for health centers most are operating on a 1 to 3% margin, many of them in the red. That was before we started trying to grapple with all of the issues that we're talking about here. So the amazing thing about health centers and these, supporting programs is that they're masters of figuring it out. Adrian, Dr. Waits, Dr. Kotri, these people figure it out because they care and they're so invested in their communities. And frankly, their community is their people. They are employing people in their community. And so they are often the largest employers. They are the economic engine. And so figuring it out is what they do because there is enormous need. But I will be honest, I was very lucky to start working with health centers in 2005. I have never seen these kind of challenges concurrently all at once. And I think what we're talking about here is that something has to give. There are a couple different paths to doing this, to seeing increased funding in Congress right now. The roadmap is there. The history of bipartisan support is there. But the need is there too. And we're so grateful for that bipartisan support and for the ongoing negotiations, but the urgency cannot be overstated. And so we've been talking a lot about what's at stake, but I want to switch gears a little bit to the need, the continued need. All of you have spoken to this a little bit, but what can we do with more? You know, like with an additional investment, what does that look like? So, Perinda, do you want to start us there?
Well, I think, you know, I had alluded to this in terms of what we're seeing in terms of demand. One area where clearly we want to invest more is addressing the mental health needs and behavioral health needs of our communities, particularly children. So we have, you know, a number of clinicians in the schools. We have school-based health centers. We need more. We have school systems who come to us and say, can you be at our school? And we can't. You know, and we're good, as we've said, we're scrappy, we're creative, we're used to stretching resources and scarcity. I mean, that's kind of built into our DNA. But you know, our commitment is to quality, is to integrity and in care, and it breaks our hearts to say we don't have it, particularly to our schools, where you know they have probably have been as impacted in so many ways. The other area that, you know, we are seeing kind of so much need, as you said, are the social drivers of health, transportation, food insecurity. There's so much need just to help address some of the environmental concerns. One of the more recent challenges that our patients, particularly our patients who are living in certain communities with some, you know, very challenging environmental and social metrics, is really environmental hazards and climate-related adverse events. So we've got people who are experiencing heat waves with no air conditioning, cold snaps, freezing spells with no heat. People have asbestos, all these things are in their home. So we now are facing new threats to health and safety. And so we're used to adapting, but now we're looking at an entire arm of how to be a climate resilient health center and how to help our communities be more climate resilient. So, you know, in addition to continuing the work that we're doing and meeting very high demand for care, we are recognizing that our community needs are changing and growing. The demands are different, and we have to be there. If we cannot be there for our kids, we're not just looking at 1 to 3 years. We're looking at the next generation and beyond. And we take a very strengths-based approach. We know our strengths. We know our patients have tremendous potential. Our communities do. And so we don't see it as like fixing something for them. We see it really as we're part of uplifting each other. And so how do we build on the richness of our communities and address those needs? But those are some areas where we are looking at, and frankly, people are telling us we need you. And so, you know, not to sustain funding, but increase funding is going to help our country grow, our communities thrive, our economy thrive.
Thanks, Perinda. Adrienne, I would love it. So, you know, as I do, that even with the investment in the National Health Service Corps by necessity, honestly, over the past few years, there's still, I think, thousands of health profession shortage areas. There are still countless communities across the country that lack good access to care based on the number of providers in serving in their community. But so can you speak to, for the National Health Service Corps, what does that increased funding look like? And just give a little bit more color to that, please.
Yeah, that return on investment that Dr. Waits and Dr. Khatri eloquently discussed, really that return on investment with a more robust investment in the National Health Service Corps, that means saving lives. That means improved quality of lives for the 99 million United States residents that live in health professional shortage area. That impacts those 99 million residents. That's roughly, if my census numbers I'm remembering correctly, that's about a third of our nation live within the health professional shortage areas. You know, the current budget for the National Service Corps, only about 11% of the scholarship recipients are able to be funded because of a lack of budget. I've often wondered, do we lose those 89%, if my math is correct, those 89% of applicants, do we lose them to go into something other than primary care? Do we lose them to not be able to afford to practice? Do we not enable them to practice within one of these health professional shortage areas? And for the loan repayment program, there's a large amount, roughly about a third of applicants are turned away. And at times that has gotten down to 50, has increased to 55% looking at the year of our applicants are turned away to the loan repayment program because of a lack of budget. We know that to impact and do away with the health professional shortage area, that roughly we would need to grow from about the 20,000 National Health Service Corps clinicians that Amanda discussed. We would need to grow that to about 36,000 clinicians in order to impact every one of those 99 million patient lives that we described that live within health professional shortage areas. So again, that return on investment means that at 2 a.m, when a mother has a 2-year-old with a really bad ear pain and has an ear infection, that mother and that child can get treatment. When that laboring mother comes into the hospital and needs to be delivered by a maternity care provider, whether it be a family physician, a nurse midwife, or an obstetrician gynecologist, that provider may be a National Health Service Corps clinician. And if there's not budget to support those providers, they may not be there to deliver that mother. This may be the opportunity for opioid use disorder treatment for our vulnerable patients that are trying to improve their lives and save their lives with opioid use disorder treatment. That provider may be a National Health Service Corps provider if there is budget, or it may not be. So again, these programs, all of these programs that we've described, from the Teaching Health Center program to the National Health Service Corps to the federally qualified health centers, these programs are all safety net programs that save and improve lives for our vulnerable amongst us.
Thanks, Adrian. We're getting toward the end of our hour here. And so I do want to just remind folks, if you have questions, please feel free to add those to the chat. You can also email us if you're feeling shy and you don't want to have the conversation, and or if there's follow-up to the discussion, including our phenomenal panelists. You know, we brought them here because they are experiencing this firsthand, and we wanted you to hear from them. Dr. Waits, I want to just pose the same question to you. I know you talked about what does flat funding look like, but also, do you want to just paint the picture of, okay, if there were more resources with the Teaching Health Center program, what does that look like? You know, what is the future? You know, I am definitely an optimist, and I am also somebody who appreciates the exercise of a magic wand. You know, what does that look like? Because we have to have a place to go. That's where our North Star is. So, Dr. Waits.
Sure. Well, again, so much of what Brenda and Adrian said, I agree with from the standpoint of the Community Health Center program and the National Health Service Corps. So I won't reiterate that. I just agree with it, and I'll talk about teaching health centers and what could be possible if there was an enhanced funding, and what does the need look like, and how do we match the opportunity with the need. Well, I mean, we have these health professional shortage areas. You know, one way to achieve things is for a community to get a community health center. And another way is to have loan repayment or scholarships. But another piece of this triangle is to have graduate medical education in rural areas. So, you know, I mentioned earlier our story in Bibb County, Alabama, how we went from being one of the most underserved rural counties in the state of Alabama to having a community health center, and embedded within that an ACGME accredited family medicine residency supported by the Teaching Health Center GME program. We've 36 alumni just from that rural track alone. 75% of them are working in underserved areas. 43% of them are working in rural areas, 3 times the national average. And so think of all of the other rural communities that would love to be a part of a teaching health center, that maybe they've got a rural health clinic that they'd love to be a part of the community health center network, or they have a consortium that they'd love to have some GME funding to train doctors in their rural area, not for a 1-month shadow rotation, but for a 3-year embedded curriculum where they really learn, the social determinants of health. They really learn the cross-cultural communication needed in their rural area or in their urban underserved area. And they feel confident and competent at the end of those 3 years to say, I can do this. I can do this, this reason that I went to medical school. It's possible for me to do. I can get loan repayment, and now I'm comfortable in this milieu that I wanted to be in anyway. So, for us, just to put a story on it, and this is just our story, but there are 90 some odd other stories like this and others that aren't in the Teaching Health Center Development Program. But we wrote a grant, a rural residency planning and development grant a year ago, because Perinda was talking about the extreme mental health shortages. Well, as you might imagine, that's true in Alabama. So we envisioned a rural psychiatry residency. We have developed this accreditation pathway to build this program out, and we are going to need some sort of graduate medical education funding pathway to be able to train psychiatrists in rural areas, and then to be able to recruit and retain them in rural areas where they, as a whole, at least in the Alabama context, they primarily aren't. And so this program is shown to be a success. With enhanced funding, we could have more success in a broader parts of the country. So I think
Thanks,
there's a
Dr.
real
Waits.
opportunity. Yeah.
Yeah, there are. We do have a couple questions in the chat. We're short on time, but I will just quickly respond in terms of where negotiations are, what we're anticipating in the Senate. Negotiations are ongoing. You've heard us mention a number of times the deep bipartisan support, which we're so grateful for, and that continues. We have champions on both sides of the aisle that are continuing to fight and push. In the Senate in particular, I think that there are ongoing discussions about, everything from offsets to duration to, the other challenges and priorities that they're competing with, or not competing with, but coping with. I think it's a little bit too early to predict sort of what may happen, but you have heard us speak in, specific detail about the harm that can come from another CR, whether it be another month or something longer in duration. So we are advocating as hard as we can through those negotiations to see as much investment as possible and for as long a duration as possible. The implications of continuing to delay this are human. It is human. It comes back to patients. And so that is the message we continue to deliver on the Hill. I think members of the Senate understand that. I will just call out, and this may not be a popular statement, but I will say it. When this country needs to come up with billions of dollars, they do. Overnight, they come up with that those dollars arrive. And the need is real. I don't diminish when that happens, but the reality is they can come up with the dollars. And these 3 programs need the dollars. So as they continue to have negotiations, I personally have reached a point where it's down to people and it's down to the wire, and it needs to get done. So yes, there are lots of really difficult, challenging, tragic issues going on both inside our country and outside of our country that also need our attention. But these programs, I cannot overstate the importance. And Congress knows it. So whether it's the House or the Senate, it needs to get done. The last question here, which I think is a really good one in the last 2 minutes, do we have recommendations on what we can do coming out of this call? I'm going to take liberty here and just say, if you are working on the Hill, thank you. Please continue to do your good work. You've heard a lot of information. If we can be a support and a resource to you as you continue these conversations and negotiations, we want to. Let us know if you have questions or we can be supportive. For those of you from the media, please follow up. We are happy to give you more information and more context if it's useful. And for the advocates that are on the line, we still have work to do. They need to hear from you. I'm so grateful to Dr. Khatri, to Dr. Billings, and to Dr. Waits and Christine for being a part of the conversation today. These conversations are what make the difference. And so the advocacy that we're talking about, and if there is one thing we come out of today doing, it is continuing to have those conversations with our congressional folks, with members of the media, across our partners in the community, so that everybody understands what's at stake and we can all work together to see a solution. So we're 1 minute till, which is miraculous, but just a huge thank you. Again, big thanks to Sandy Appleby on our team for getting this put together. And again, to our panelists and to Christine for all the amazing work and for the conversation today. And hope everybody has a fantastic Tuesday, and on we go. I know we will get this done and the future can be bright. So thanks, guys. Take care.
Thank you.
Yeah.
Thanks.
Thank you so much.